Hello and welcome to the Coding Corner, Medical Coding Education. Today we will be covering the ICD-10-CM chapter-specific coding guidelines for Chapter 2, 3, and 4. My name is Kristen Robinson. I am a coder, auditor, and educator, and let's get into it. First, we have Chapter 2. These are the neoplasms. This is codes C00 through D49. The general guidelines for this chapter include benign, malignant, metastatic, in situ, uncertain histologic behavior, primary malignant neoplasms overlapping boundaries, and malignant neoplasms of ectopic tissue. A primary malignant neoplasm that overlaps two or more contiguous or next to each other sites should be classified to the subcategory 0.8 for overlapping lesion, unless there is a combination that is specifically indexed elsewhere. For multiple neoplasms of the same site that are not contiguous, such as tumors in different quadrants of the breast, codes for each site should be assigned. When we talk about malignant neoplasms of ectopic tissue, malignant neoplasms of ectopic tissue are to be coded to the site of origin mentioned. For example, ectopic pancreatic malignant neoplasms involving the stomach are coded to malignant neoplasm of pancreas unspecified or code C25.9. The neoplasm table in the alphabetic index should be sequenced first. However, there is an exception to this. If there is a histologic term documented, that term should be referenced first. Rather than going immediately to the neoplasm table in order to determine which column in the neoplasm table is appropriate. For example, if the documentation indicates adenoma, refer to the term in the alphabetic index to review the entries under this term and the instructional note that says, see also neoplasm by site benign. The table provides the proper code based on the type of neoplasm and the site. It is important to select the proper column in the table that corresponds to the type of neoplasm. The tabular list should then be referenced to verify that the correct code has been selected from the table and that a more specific site code does not exist. If you want additional information on this, you can reference section 1C21 for the factors influencing health status and contact with health services status for information regarding Z15.0 codes for genetic susceptibility to cancer. So next we're going to cover admission or encounter for treatment of a primary site. Okay, so if the malignancy is chiefly responsible for occasioning the patient for the admission, encounter, and treatment, it is directed at the primary site. Designate the primary malignancy as the principal or first listed diagnosis. Now, the only exception to this guideline is if there is administration of chemotherapy, immunotherapy, or external beam radiation therapy, which is chiefly responsible for occasioning the admission or encounter. In these cases, you want to assign the appropriate Z51 code as the principal first listed diagnosis, and then the underlying diagnosis or the problem for which the service is being performed as the secondary diagnosis. Okay, so now if the admission or encounter is for the secondary site or the metastasis, then the secondary neoplasm should be designated as the principal diagnosis, even though the primary malignancy is still present. When we are coding for sequencing of complications, coding and sequencing of complications associated with malignancies or with therapy thereof are subject to these guidelines. When we have anemia associated with malignancy, when the admission or the encounter is for management of anemia associated with malignancy, and the treatment is only for the anemia, the appropriate code for the malignancy is sequenced as the principal or first listed diagnosis, followed by the appropriate code for the anemia, such as D63.0 for anemia in neoplastic disease. Number 2, anemia associated with chemotherapy, immunotherapy, and radiation therapy. When the admission or encounter is for management of anemia associated with an adverse effect of the admission of the chemotherapy or immunotherapy, and the only treatment is for the anemia code is sequenced first, followed by the appropriate codes for the neoplasm and the adverse effect. So, for instance, T45.1x5, and then you would use the additional digit as appropriate. Adverse effect of a anti-neoplastic and immunosuppressive drug. When the admission or the encounters for management of an anemia associated with an adverse effect of radiation, the anemia code should be sequenced first, followed by the appropriate neoplasm code Y84.2 for radiological procedure and radiotherapy as the cause of abnormal reaction of the patient, or of the latter complication without mention of misadventure at the time of the procedure. Number 3, when we have management of dehydration due to the malignancy. When the admission or the encounter is for management of dehydration due to the malignancy, and they are only treating the dehydration. Let me say that again. They are only treating the dehydration, okay? This means that they're providing intravenous rehydration. The dehydration would be sequenced first, followed by the code or codes for the malignancy. Number 4, treatment of a complication resulting from surgical procedure. When the admission or encounter is of treatment for a complication resulting from a surgical procedure, we need to make sure that we designate the complication as the principal or first listed diagnosis if the treatment is directed at resolving the complication. Next, primary malignancy that has been previously excised. So this is going to come from code category Z85. When a primary malignancy has been previously excised or eradicated from its site, and there is no further treatment directed to that site, and there is no evidence of an existing primary malignancy at the site, the code from category Z85, or personal history of malignant neoplasm, should be used to indicate the former site of the malignancy. Any mention of extension, invasion, or metastasis to another site is coded as a secondary malignant neoplasm to that site. The secondary site may be the principal or first listed diagnosis with Z85 used as the secondary code. If you would like more information on this, you can see section IC2.T for secondary malignant neoplasm of lymphoid tissue. Next, we have admissions or encounters involving anti-neoplastic chemotherapy, immunotherapy, and radiation therapy. Number 1, episode of care involves surgical removal of the neoplasm. So when there is an episode of care that involves the surgical removal of a neoplasm, the primary or secondary site, followed by adjunct chemotherapy or radiation treatment during the same episode of care, the code for the neoplasm should be assigned as the principal or first listed diagnosis. Number two, if there is a patient admission or encounter chiefly for the administration of the anti-neoplastic chemotherapy, immunotherapy, or radiation therapy, for the treatment of the neoplasm, assign a code from Z51.0. So that could be for the encounter for the neoplastic radiation therapy, Z5111 for the encounter of anti-neoplastic chemotherapy, Z51.12 for the encounter for the anti-neoplastic immunotherapy as the first listed or principal diagnosis. If the reason for the encounter is more than one type of anti-neoplastic therapy, code Z51.0 and codes from subcategory Z51.1 may be assigned together, in which the case one of these codes would be reported as the secondary diagnosis. When the malignancy for which the therapy is being administered should be assigned as the secondary diagnosis. If a patient admission or encounter is for the insertion or implementation of a radioactive element such as Brady therapy, the appropriate code for the malignancy is sequenced as the principal or first listed diagnosis. Code Z51.0 should not be assigned. I would like to say that again. Codes from Z51.0 should not be assigned. Number three, patient is admitted for radiation therapy, chemotherapy, or immunotherapy, and then they develop complications. So when a patient is admitted for the purpose of external beam, radiotherapy, immunotherapy, or chemotherapy, and then subsequently has complications from uncontrolled nausea and vomiting or dehydration, the principal or first listed diagnosis is Z51.0. Encounter for anti-neoplastic radiation therapy or Z5111, encounter for anti-neoplastic chemotherapy or Z5112, encounter for anti-neoplastic immunotherapy, followed by any codes for the complications. Okay, so now we're talking about admission for the encounter to determine the extent of the malignancy. When the reason for the admission encounter is to determine the extent of the malignancy or for a procedure such as a paracentesis or thoracentesis, the primary malignancy or appropriate metastatic site is designated as the principal or first listed diagnosis, even though chemotherapy or radiotherapy is being administered. When you have signs, symptoms, or abnormal findings listed from chapter 18 associated with neoplasms. Okay, so symptoms, signs, and ill-defined conditions listed in chapter 18 are characteristic of or associated with an existing primary or secondary site malignancy, cannot be used to replace the malignancy as the principal or first listed diagnosis, regardless of the number of admissions or encounters for treatment and care of the neoplasm. Okay, I'm going to say that again. They cannot be used to replace the malignancy as principal or first listed diagnosis, regardless of the number of admissions or encounters for treatment and care of the neoplasm. If you would like more information on this, you can see section 1C21 for the factors influencing health status and contact with health services encounter for prophylactic organ removal. Next up, we have the admission or encounter for pain control management. I apologize for the pause. You want to make sure that you see section 1.c.6 for information on coding the admission or encounter for pain control management. When we have a malignancy in 2 or more non-contiguous sites, a patient may have more than one malignant tumor in the same organ. These tumors may represent different primaries or metastatic disease. Depending on the site, should the documentation be unclear, the provider should be queried as to the status of each tumor so that the correct codes can be assigned. Next up, we have disseminated or malignant neoplasms unspecified. Code C80.0, disseminated malignant neoplasm unspecified, is for use only in cases where the patient has advanced metastatic disease and no known primary or secondary sites are specified. I want to make it clear, it should not be used in place of assigning codes for the primary site and all known secondary sites. When we have malignant neoplasm without specification of site, code C80.1, malignant primary neoplasm unspecified, equates to cancer unspecified. This code should only be used when no determination can be made as to the primary site of the malignancy, and this code should rarely be used in the inpatient setting. When it comes to sequencing neoplasm codes, we have several steps that we need to make sure that we follow. Number 1, encounter for treatment of the primary malignancy. So, if the reason for the encounter is for treatment of primary malignancy, you want to make sure that you assign the malignancy as the principal or first listed diagnosis. The primary site is to be sequenced first, followed by any metastatic sites. Now, when the encounter for treatment is of a secondary malignancy, the metastatic site or sites are designated as the principal first listed diagnosis, and the primary malignancy is coded as an additional code. When patients that are pregnant have a malignant neoplasm, okay, remember, you have to be very familiar with Chapter 15 codes because they take precedence, okay? When a pregnant patient has a malignant neoplasm, a code from subcategory 09A.1 with the additional digit based on the situation and documentation supporting it, malignant neoplasm complicating pregnancy, childbirth, and the puerperium. This should be sequenced first, followed by the appropriate code from Chapter 2 to indicate the type of neoplasm. When there is an encounter for a complication associated with a neoplasm, and the treatment is only for the complication, the complication is coded first, followed by the appropriate code or codes for the neoplasm. The exception to this guideline is for anemia. When the admission or encounter is for management of anemia associated with malignancy, and the treatment is only for the anemia, the appropriate code for the malignancy is sequenced as the primary or principal first listed diagnosis, followed by D630 for the anemia and neoplastic disease. Number 5, when there is a complication from a surgical procedure for treatment of a neoplasm, designate the complication as the principal or first listed diagnosis and see the guideline regarding coding of a current malignancy versus personal history to determine if the code for the neoplasm should be assigned. Lastly, if there is a pathologic fracture due to a neoplasm, okay? So when there is an encounter for a pathological fracture due to a neoplasm, and the focus of the treatment is the fracture, a code from subcategory M84.5 for pathological fracture and neoplastic disease should be sequenced first, followed by the code for the neoplasm. If the focus of the treatment is the neoplasm with an associated pathological fracture, the neoplasm should be coded first, followed by a code from M84.5 for the pathological fracture. So now we're going to talk about a few other areas in this chapter. Current malignancy versus personal history of malignancy. When a primary malignancy has been excised, but further treatment such as additional surgery for the malignancy, radiation therapy, or chemotherapy is directed to that site, the primary malignancy code should be used until the treatment is completed. When a primary malignancy has been previously excised or eradicated from its site and there is no further treatment of the malignancy directed to that site, and there is no evidence of an existing primary malignancy at that site, a code from category Z85 for the personal history of malignant neoplasm should be used to indicate the former site of the malignancy. Codes from subcategories Z85.0 through Z85.85 should only be assigned for the former site of a primary malignancy, not the site for the secondary malignancy. Code Z85.89 may be assigned for the former site or sites of either a primary or secondary malignancy. And again, if you need more information on this, you can see section 1C21. For leukemia, multiple myeloma, and malignant plasma cell neoplasms that are in remission versus personal history. When we talk about the categories for leukemia and category C90 for multiple myeloma and malignant plasma cell neoplasms, have codes indicating whether or not the leukemia has achieved remission. There are also codes Z85.6 for personal history of leukemia and Z85.79 for personal history of other malignant neoplasms of lymphoid, hematopoietic, and related tissues. If the documentation is unclear as to whether the leukemia has achieved remission, the provider should be queried. Again, if you need additional information, see section 1C21. So the next three we're just going to breeze over because you can go straight to section 1C21 for more information. So for aftercare following surgery for neoplasm, follow-up care for completed treatment of a malignancy, and prophylactic organ removal for the prevention of a malignancy, you can go and read more on that within that section. Malignant neoplasm associated with transplanted organs. So, a malignant neoplasm of a transplanted organ should be coded as a transplant complication. So, you want to make sure that you assign the first code from category T86 for complications of transplanted organs and tissue, followed by C80.2 for malignant neoplasm associated with transplanted organ. Then you'll use an additional code for the specific malignancy. When we have breast implant associated anaplastic large cell lymphoma, otherwise known as BIA-ALCL, this is a type of lymphoma that can develop around breast implants. In this case, you would assign a code from C84.7A for anaplastic large cell lymphoma, ALK negative breast for BIA-ALCL, or C84.7B for anaplastic large cell lymphoma, ALK negative in remission for BIA-ALCL in remission. Do not assign a complication code from Chapter 19 in this scenario. With secondary malignant neoplasms of lymphoid tissue, when a malignant neoplasm of lymphoid tissue metastasizes beyond the lymph nodes, a code from category C81 through C85 with a final character identifying the extranodal and solid organ sites should be assigned rather than a code for the secondary neoplasm of the affected solid organ. For example, for metastasis of a diffuse large B-cell lymphoma to the lung, brain, and left adrenal gland, assign code C83.398 for diffuse large B-cell lymphoma of other extranodal and solid organ sites. I apologize, I went too fast. Okay, now we are going to cover Chapter 3. Now, for Chapter 3, this is the disease of blood and blood-forming organs and certain disorders involving the immune mechanism. This is codes D50 through D89. Now, we do not have specific guidance in this section at this time. So, we are going to move forward to Chapter 4. Chapter 4 is the endocrine, nutritional, and metabolic diseases. These are your codes E00 through E89. First up, and everyone seems to be their favorite in this chapter, is diabetes. Okay, so with diabetes, you have pre-symptomatic type 1 diabetes and type 2 diabetes, and we're going to get into this further. So, with diabetes mellitus, codes are combination codes that include the type of diabetes mellitus, the body system affected, and the complications affecting that body system. As many codes within a particular category as necessary to describe all of the complications of disease that may be used. They should be sequenced based on the reason for the particular encounter. For example, if a patient is being seen for diabetes with end-stage renal disease, E11.22 would be your combination code, which is diabetes with CKD, and then you would want to code your secondary code N18.6 for the end-stage renal disease. Remember, assign as many codes from categories E08 through E13 as needed to identify all of the associated conditions that the person has. So we have types of diabetes that we're going to be covering. Remember, the age of the patient is not a sole determining factor, though most type 1 diabetics develop the condition before reaching puberty. For this reason, type 1 diabetes mellitus is also referred to as juvenile diabetes. When we talk about pre-symptomatic type 1 diabetes mellitus, you want to use codes from E10.A for type 1 diabetes mellitus pre-symptomatic are assigned for early stage type 1 diabetes that predates the onset of symptoms. Now, this is a new section that we're getting ready to cover for 2026. Type 2 diabetes mellitus in remission. Code E11.A, type 2 diabetes mellitus without complications in remission, is assigned based on provider documentation that the diabetes mellitus is in remission. If the documentation is unclear as to whether the type 2 diabetes mellitus has achieved remission, the provider should be queried. For example, the term resolved is not synonymous with remission. I'll say that again. The term resolved is not synonymous with remission. The type of diabetes mellitus is not documented. When the type is not documented, the default is type 2 diabetes. So if you have type 2 diabetes or it is not documented the type, you'll want to use a code from E11. If it's unspecified, that would be E11.9. When we have diabetes and the use of insulin, oral hypoglycemics, and injectable non-insulin drugs, if the documentation in the medical record does not indicate the type of diabetes, but does indicate that the patient uses insulin, code E11, type 2 diabetes mellitus should be assigned. Additional codes should be assigned from category Z79 to identify the long-term or current use of insulin, oral hypoglycemic drugs, or injectable non-insulin anti-diabetic as follows. So, if a patient is treated with both oral hypoglycemic drugs and insulin, you'll want to use Z79.4 for the current long-term use of insulin and code Z79.84 for the long-term or current use of oral hypoglycemic drugs to be assigned. If the patient is being treated with both insulin and injectable non-insulin anti-diabetic drugs, assign a code Z79.4 for the long-term use of the insulin, and then Z79.85 for the current use of the injectable non-insulin anti-diabetic drugs. If the patient is being treated with both oral hypoglycemic drugs and an injectable non-insulin anti-diabetic drug, assign Z79.84 and Z79.85. And just a final tip here, code Z79.4 should not be assigned if insulin is given temporarily to bring a type 2 patient's blood sugar under control during encounter. Okay, that is for a long-term use. This is not for a one-time or for a very short period of time use just to get the patient's blood sugar under control. If you want more information about diabetes mellitus in pregnancy and gestational diabetes, you'll want to see section 1C15 for diabetes mellitus in pregnancy, or section 1C15 for gestational or pregnancy-induced diabetes. When there is a complication due to an insulin pump malfunction, there's a couple things to keep in mind here. Number one, if it is an underdose of insulin due to insulin pump failure, the underdose of the insulin due to the insulin pump failure should be assigned to a code from subcategory T85.6 for a mechanical complication of other specified internal and external prosthetic devices, implants, and grafts that specify the type of pump malfunction as the principal or first listed diagnosis, followed by T38.3x6, underdosing of insulin and oral hypoglycemic or anti-diabetic drugs. Additional codes for the type of diabetes mellitus and any associated complications due to the underdosing should also be assigned. When there is an overdose of insulin due to insulin pump failure, the principal or first listed code for the encounter due to insulin pump malfunction resulting in an overdose of insulin, you should use code T85.6 for the mechanical complication of other specified internal and external prosthetic devices, implants, and grafts, followed by code T38.3x1 for poisoning by insulin and oral hypoglycemic or anti-diabetic drugs, accidental or unintentional. For secondary diabetes, codes under category E08 for diabetes mellitus due to underlying condition, or E09 for drug or chemical-induced diabetes, and E13 for other specified diabetes mellitus, identify complications and manifestations associated with secondary diabetes mellitus. Secondary diabetes is always caused by another condition or event. For example, cystic fibrosis, malignant neoplasm of pancreas, pancreatectomy, or an adverse effect of a drug or poisoning. When secondary diabetes mellitus and the use of insulin, oral hypoglycemic drugs, or injectable non-insulin drugs are being used, we will follow the same guidelines as we previously discussed from the category Z79. So you have Z79.4 for the long-term use of the insulin, Z7984 for the oral hypoglycemic drugs, and then you have Z79.85 for the injectable non-insulin anti-diabetic drugs. You follow the same guidelines here. Again, remember Z79.4 should not be assigned if insulin is given temporarily to bring a secondary diabetics patient's blood sugar up to under control during a single encounter. So when we talk about assigning and sequencing secondary diabetes codes and then the causes, when we sequence the secondary diabetes codes in relationship to codes for the cause of the diabetes, it is based on the tabular list instructions for code categories E08, E09, and E13. For secondary diabetes due to pancreatectomy, for post-pancreatectomy, Diabetes mellitus, or lack of insulin due to surgical removal of all or part of the pancreas, assign code E89.1 for post-procedural hypoinsulinemia, and assign a code from E13 is the principal or first listed diagnosis, and a code from subcategory Z90.41 for the acquired absence of pancreas as an unlisted or as an additional code. Additional code. For secondary diabetes due to drugs, this may be caused by an adverse effect of correctly administering the medication, poisoning, or a sequela of poisoning. See section 1C19.E for coding an adverse effect and poisoning, and section 1C20 for external cause code reporting. Lastly, for obesity, the obesity codes in category E66, overweight and obesity, include codes related to the body, the cause of the obesity, such as drug-induced obesity, which would be your E66.1, your codes related to the effects of obesity, such as codes E66.2, morbid or severe obesity with alveolar hypoventilation. There are other codes related to obesity in other categories of the classification, such as E88.82 for obesity due to disruption of MC4R pathway, and codes in fifth character subcategory O99.21 for obesity complicating pregnancy, childbirth, and the puerperium. So now we have, for 2026, we now have obesity classes. The obesity class codes in subcategory E66.81 for obesity class require a fifth character to convey the severity of the obesity. The obesity class should be documented in the medical record by the provider for these codes to be assigned. The obesity class codes can be reported with other obesity codes in the classification found in chapters 4 and 15 to fully describe the condition. However, if both class 3 obesity and morbid obesity are documented, only a code from class 3 obesity should be assigned, as it is more specific. Okay, guys, that closes us out for today's presentation. The only resource for today's presentation is the ICD-10 CM Fiscal Year 2026 Guidelines. Remember, if you don't already follow this page, the Coding Corner, please make sure you hit that bell to be notified and follow the page. And also check us out over on Facebook for the Coding Corner Facebook group. And I'm also on LinkedIn if you would like to contact me there as well. I hope everyone has a great rest of your day, and we'll see you for the next episode.